ARDS. So our talk will be more discussing what we know from the past, present, and what is the future. Okay. So before going ahead, at least for those who are not familiar with a couple of abbreviations we use in the ICU, so these are the abbreviations that I'll be commonly using them in our talk. Before going further, we'll talk some cases, 3 cases seen in different times, and based on the resources available on those three different times. Along with that, at least you'll try to understand how the history of ARDS started, what definitions, and how the management changed over time. So let's start with a case that I saw. These are the real-time cases I saw, seen in 2009. That's about almost 25 years ago. So a patient comes in, 17 years old male, comes to the emergency department with altered level of consciousness and had fever for past 4 days. The first thing what we do in our emergency department, our good about our nurses, they take our vitals. These are the vitals. The patient's is okay, tachycardic, tachypneic, temperature is high, sets were 65 on room air. And at the same time, the Glasgow Coma scale was 10/15. So I know that the whole case is based on ARDS, and so this is ARDS. I just skip through the whole history and everything, coming to the point. So the first thing was malaria. FBS was more than 1,000. You see the old panels. I won't talk so much in details. All the parameters were all okay. Just WBC was high, neutrophils were high. Let's go. Focus on ARDS. If we are talking ARDS, is looking at the blood gas, arterial blood gas. So the arterial blood gas, you see 2 components. The whole blood gas component is PO2, PCO2, bicarb, and electrolytes is your plus point. So here, what we look at the level of how much the patient is hypoxemic, level of hypoxemia. That is estimated on the ratio of PaO2, FiO2. Okay, we'll talk about this if anyone is not aware of those hypoxemic ratios. So this was 75. This is considered is extremely severe ARDS. The patient was receiving FiO2 of 100%. This is the X-ray, bilateral infiltrates. Okay, and so the differential comes in severe malaria, being altered level of consciousness, meningitis, ARDS. Since the talk is ARDS, we'll be just talking ARDS. So at least you get some idea. Okay? So ARDS is never a primary diagnosis, the secondary diagnosis. And what led to it, in this case, is malaria. Patient was not really stable, could not protect the airway, breathing was really bad. So the patient, we decided to intubate and manually bagged with non-rebreather mask. Now, what happened to the patient? That is, I'm talking about 15 years ago. At that time, patient, we didn't have any ventilator, and the patient passed away. We learned from our lesson, like hard lesson, that ventilator is really important to save someone's life. Coming to case number 2, this was seen 5 years after the first case, 2015, 10 years from now. 23 years old, female, shortness of breath for a day. Okay. BP is pretty okay, tachycardic, tachypneic, temperature is high, sets were 85 on mask, 10 liters per minute. That is approximately taking about 60% of FiO2. DCS was apparently okay, 15/15 comparative to the last case. That's the first X-ray on admission. You can see bilateral infiltrates, patient differentials, malaria, can be pneumonia, and ARDS contribute. Same thing. So all these 3 cases will be talking only based and making it more uniform, malaria cases. Okay? Malaria was positive. In this case, we didn't have the luxury of a blood gas machine. But what we did had as a non-invasive pulse oximeter. SpO2. We talk about that what if you don't have a blood gas, you can use an SpO2 to uh, make a ratio out of it and then understand what the level of hypoxemia the patient has. So based on that calculation, the ratio of SpO2 the patient had with the FiO2 what we are given was coming to 142. So that was counted as moderate ARDS. So what we had done, patient, we started, let's put on the patient on a CPAP, non-invasive ventilation, give a try. Right. Okay, we managed to bump up the saturations with the oxygen and the CPAP, but what was the worry is the patient was running a marathon, was very tachypneic. He will eventually get tired. So what we decided, get the patient intubated, and lately we had a ventilator here. And if you see, the patient's mode was kept tidal volume 360. We initially started 100 FiO2, respirator 16, and started with higher PEEP. So we started initially PEEP 16, gradually went 5, FiO2 90 to 40s, the normal modes. Sixth day, the patient as well decided to extubate, wind down to oxygen mask, nasal prong, ambulation. Ninth day, the patient gets discharged. So you can see the difference, case 1 and case 2. The last case. Okay, so this is the X-ray post-extubation, and this is the third day. I would say on the 9th day from the time of admission. The third case was seen this year in January 2025. Apparently, those patients were adults. This was a child, 7-year-old, who presented to our ER with high-grade 3 days, altered level of consciousness, and I was a bit jaundiced for quite some days. Those are the BPs. I think that's a normal heart rate for the child, or maybe a bit tachycardic, tachypnic, temperature high, hypoxemic with SpO2 75, but taking on mask 10 liters. There's approximately 60 to 80% of FiO2. At that moment, the patient ACS was 8/15. And as I mentioned, the patient was jaundiced. What was done on the patient? The first thing, you see the X-ray, evidence of bilateral infiltrates. Okay. And we put a use of an ultrasound. I put an ultrasound. This is a blue protocol that you can put. I know that's not the right on 3 zones, bilateral chest, and see the B lines. Same case, as I said, is uniform, all malaria. Okay. Lately, we had a blood gas at this time this year, and we measured the PaFiO2 ratio. The ratio on the amount of oxygen getting 60%, 75 divided by 0.6 comes to 125. That counts as moderate ARDS. So we decided the patient was very unstable, GCS was very low, could not control the airway, breathing was not that good. Decided let's intubate the patient and put on the ventilator. The patient was given good PEEP, maintained good plateau pressures, good hemodynamics, and we went everyone happy. And we thought like on the third day, the patient may get extubated. But and then during that time, since the patient was jaundiced and possibly there was anemia, so the patient ended up getting also 1 or 2 units done during this day. So on the third day, being very optimistic, thinking that, okay, we'll extubate the patient, but this happened. Instead of improving, his all parameters went haywire. He ended up becoming tachypnic despite on the vent. Stats were on the lower side. and amount of oxygen initially was using 40, bumped up to 80. So, and when we ended up doing the blood gas and looking at the level of hypoxemia based on the ratio, so his PFI ratio from 125 dropped to 53. So that's more severe. What happened here? Apart from the severe malaria, which led to ARDS, there might be three other contributing things that might lead to worsening of the situation. Could be ventilator-induced lung injury, could be ventilator-associated pneumonia, or the blood he received 2 units while he stayed, transfusion-associated lung injury. What was done for the patient? He was heavily sedated, paralyzed, with an infusion over the period of 36 hours, introduced corticosteroid, dexamethasone. Proning was done every 12 hourly, and the PEEP was opted on the higher side, positive and expected pressure. That's about 15. And minimizing the amount of FiO2 to prevent hyperoxia. After supine and prone every 12 hours or 2 days, on the 7th day, the patient gets extubated. And finally, promise of 10th day, the patient gets discharged. So this is the post-extubation X-ray, and seeing the difference of the previous one. So as I mentioned, even to Moise, it's a triad, okay, which everyone knows about it. Or for those who are unaware of ARDS, as I always say that it's not a primary diagnosis, it's a secondary diagnosis, which is from an insult happened. So it's has to have bilateral pulmonary infiltrates, level of severe hypoxemia, and it should not be evidence of cardiogenic pulmonary edema. So basically, this is not a transudative, rather than it is exudative pulmonary edema. In other terms, a non-cardiogenic pulmonary edema. If you have to put a microscope and then look at how your cells look like, so our pathologist fellow would find this as diffused alveolar damage. Okay? Now, let's go back in time about ARDS. I know Berlin was a brand new thing, but we have to know where it started. A French doctor, he reported in 1820. Unfortunately, at that back of time of technology, he could not get a better answer, so he defined or reported in his papers as idiopathic pulmonary edema. World War I, II hit. Many doctors were dealing with all the trauma patients. Unfortunately, those trauma were not even related to the chest. Patient ended up getting bilateral lung pathology, and that was defined as, in the reports, as a short lung. The best report was published by one of the father in ARDS knowledge, and his name is David Oshbaugh. So he published a case series of 12 patients. So he is the person that he tried to identify patients who ended up getting ARDS, and he well managed them by introducing PEEP. One of the best first ventilators which you see on the right side, that is where he introduced PEEP and introduction of steroids. And with that papers, he could have managed to publish in the Lancet. But unfortunately, everyone was really in dilemma, what is really ARDS? So till 1994, a committee, American European Society, if they sat down and said, okay, we have to really define what is really ARDS. Okay? So these are just talking about the level of hypoxemia, because David Oshbaugh never defined as level of hypoxemia. So they defined in two categories: acute lung injury and acute respiratory distress. So that is defined as PaFiO2, anything less than 300, between 200 to 300, the patient will be defined, labeled as acute lung injury, whereas anything less than 200, the patient has ARDS. it has its limitations. So more further papers, more evidence came along till 2012. That's about 13 years from now. So the definition was revised, and this was applied to patients as long as the patient have to be intubated. Did not apply to any patients who are on mask, high flow, or any other non-invasive modalities. So the patient have to be intubated and at least kept minimum of 5 centimeter of water peak. So, acute lung injury definition was removed, as you saw in the previous slide. So it was kept plain ARDS and mild, moderate, severe. So mild was defined any number based on the PaFiO2, 200 to 300, moderate, anything between 100 to 200, and severe, less than 100. Remember, these patients have to be intubated and on PEEP more than 5. What was the difference here in AACC definition in Burley? AACC, they never defined the timing. They just said acute. Acute, 1, 2 days, was not really defined. Berlin, at least they defined maximum 7 days from the time of whatever the insult happened. So the course of the disease was known. In 1994, imaging was best available was chest X-ray, and at least you could identify. In 2012, CT scan became more available and popular. So CT scan could identify, apart from the infiltrates, other pathology that might had lead to hypoxemia, echo, pulmonary pressures, and as I mentioned, the classification. Now, what is the current thing? Okay. The current thing, as I said, like we came from our past, we know the disease, we identified the definition from 1994 to 2012, and I know as we are in Tanzania and many other countries, we do not have the luxury or resources of blood gas to measure PaO2, partial pressure oxygen. So paper was published in 2017 by Kigali experts in Rwanda, and they said, okay, if we don't have PO2, why not we take SpO2 and use SpO2 and to identify the level of oxygen. By the way, that was really validated in comparison and was reckoned in this definition, and the PEEP was removed, which was recommended in Berlin. And you see the 2013 definition, they have included not only PaFiO2, but also SpO2, FiO2. And also apart from that, they have also included ultrasound, because many of the centers do not have access to chest X-ray or CT scan. And even because of the patient being so unstable, moving them from one unit to another, getting a CT scan, it's a havoc. So getting an ultrasound bedside makes up. And they have also added a definition if a patient is an IV or high flow nasal cannula, as long as the flow is more than 30, because more than 30, that's where the PEEP is provided more than 5 centimeters of water. So this is all new global definition, which was defined in 2023, published in January last year, 2024. Nothing has changed. The risk factors are the same. The timing is same. Just here on the chest imaging, ultrasound was added. Okay. Apart from that, if you see the center box for intubated patients, nothing has changed in respect to Berlin definition. Only the thing is the PEEP part is removed. But the Berlin wanted to have PEEP at least a minimum, that has been removed, and also included if you have no PO2, if you have just SpO2, you can use the SpO2 there. So the SpO2 or FiO2 less than 315, it's counted mild. Between 148 to 235, the moderate, you can see here. Okay. And the severe, I know I mentioned about the PaFiO2 less than 100. If it is somewhere less than 148, case of SpO2 FiO2. Now, for those patients who are non-intubated, maybe patients are on high flow nasal cannula or NIV. Whatever you have, whether PaFiO2, you can use it and use the same, identify the hypoxemia levels or PaFiO2 ratio. And as I mentioned, the flow has to be more than 30, and NIV, the CPAP PEEP has to be at least 5 centimeter of water. What about for those resources, like hospitals do not have all these high-end resources? You can use even an oxygen mask, and you can use SpO2 FiO2 to identify the level of hypoxemia, as long as the SpO2 has to be, when the measurement or the calculation is done, the SpO2 has to be less than 97. That's the reason, because of oxyhemoglobin curve on the top, after 97, you will not get the rightful number. So the SpO2 has to be less than 97. That is where you can do the calculation of SpO2 FiO2 ratio. So this best explains in this infographic. If you see the first patients, this first patient is intubated, had the abdominal sepsis, which led to ARDS. If it's evident with an chest X-ray, patient is intubated on FiO2 50%, have access to blood gas, PO2 is 75. The ratio for that, 75 divided by 0.5 comes to 150. That typically includes into also Berlin definition. So that has not changed, okay? And here they have not even identified the PEEP part. So that counts as moderate. What about for those patients who are on NIV or high flow? So this lady is on high flow nasal cannula, has COVID, okay? And that led to hypoxemia. It's evident with the chest X-ray. The high flow is 40 liters per minute, more than 30. Set on 80% FiO2, and sets are reaching 91. So that's less than 97, remember. So if you do the math, okay, comes to 114. That counts the patient having severe ARDS, okay, as per the global definition. What about the patients on the bottom with the patient using mask, okay, has sepsis, but unfortunately the patient do not have, the hospital do not have blood gas nor a mechanical ventilation. At least the hospital can get an idea that should I stay with the patient or escalate the therapy to refer the patient to a rightful place. This patient had, the hospital had an ultrasound. You can see the multiple B lines. Okay? Supplemental oxygen, 15 liters. That accounts like approximately 60% FiO2. The patient hits 85%, the ratio 142. So that also the new category in global definition, inconsistent with the Kigali modification. So how were the prognosis of ARDS had been always high, especially in 1990s. It was more than 60%. Till after 1994, after knowing the whole disease, how the whole pathophysiology, and how to manage based on the learned protective strategy, the mortality reduced till to date at least 40%. So, as I said in the beginning, ARDS is never a primary diagnosis. It's a secondary diagnosis, means that something leads to ARDS. Either can be pulmonary pathology or
pulmonary pathology. So pulmonary pathologies can be pneumonia. Any pneumonia, I think we just came out from the COVID era. So COVID was one of the key viral infection caused ARDS, aspiration of gastric contents, inhalation, contusion to the lung, drowning. The indirect is like on sepsis, non-pulmonary sepsis, what we just discussed in our three cases, it was malaria, nothing related to the lung, nothing related, but the patient ended up getting lung condition. Trauma, not necessary, has to be on the chest, can be even on the limb or on the abdomen. The patient gets ARDS. And other things that you can see on the slides. So, how the ARDS happens? Okay, ARDS happens because of the whole alveolar injury due to diffuse alveolar damage, which damages not only the alveolar epithelium but also damages the endothelium. Okay, what you can literally see in a good info on the left side of the normal alveolus, good epithelium layer lining, good cells, type 2 cells, blood moving nicely, good gas exchange. But on my right side, on the injury, what happens here? There is too much of cytokine release, which activates the neutrophil and damages not only the epithelium, but also the endothelium. So the consequences is that the tight junctions gets loosened up and all the protein-rich fluids gets accumulated in the interstitium. So this is just to summarize, because ARDS is more neutrophil-mediated disease. So have to have a predisposing condition which releases the cytokines and later on activates the neutrophils to the lungs, recruits all the neutrophils. That's why when you do your full blood picture, you'll see the neutrophils on the higher side, and you'll end up saying, oh, that's a bacterial infection. Well, it's not. That's the whole evil thing, hidden evil that's happening on the patient. Whereas like in case of malaria cases that I've described. So after the neutrophil gets recruited, the neutrophil releases the toxic oxygen metabolites, proteolytic enzymes, and later on in the capillaries, the endothelium gets disrupted along with the alveolar epithelium. So we started knowing more about ARDS over the past 10 years, including during the COVID was a learning point. So what we learned here, that ARDS, when it starts, it's about to heal, it passes over 3 overlapping stages. That's the stage. The first stage is the primary stage. That's the exudative stage, what I've just mentioned in my previous slide, that all the fluid gets into the interstitium. That's like in 7 to 10 days. Proliferative, that is kind of a recalibrative. There's whatever the damage happened, the debris are there, it tries to wash out. As long as there is a treatment, like you have a treatment to underlying problem, like malaria, you have a treatment to malaria to clear out the malaria. If you clear out the malaria, the patient will not go into the fibrotic phase. In case of COVID, we never had a treatment for COVID. So we were just waiting for the body to build up their immunity. So the body cannot keep on recalibrating. So the third phase, what the patient goes into is fibrosis, which happens over the period of weeks to months. So what are the consequences happens in all those phases? The loss of surfactant, the gas exchange impaired, and decreased lung compliance. And further, they identified there are 2 phenotypes, hyperinflammatory and hypoinflammatory ARDS. What's so big difference about it? Hyperinflammatory, their cytokines are in a high level. They have low protein C levels. That's why they are really highly prone to get thromboembolisms. They are very acidotic and profound shock. And saying all those things, they have a highest mortality compared to hypoinflammatory ARDS. But lower inflammatory and low mortality if the patient is applied a very high PEEP and fluid conservative strategies is applied. So some features sharing ARDS will say like, okay, there are other lung pathology can mimic ARDS. So just understand on this table, fever, acute onset bilateral infiltrates, EFiO2, ARDS meets all. But other things, pulmonary embolism, cardiogenic pulmonary edema, do not meet all. I think I will not go in details on that. You can see it very well. So coming to the favorite part, how do you treat ARDS? ARDS, so far, there are no any drug proven to prevent ARDS or treat ARDS. Numerous pharmacological therapy used, but till now we don't have the answer. But the futuristic treatment, or there is a light ahead, which we call is a goal-directed therapy. Mesenchymal stromal cells, stem cells, and epigenetics. There had been a couple of trials happening, phase 1 and phase 2, which showed promising results in moderate to severe ARDS. Let's see in the coming maybe 20 years to come, maybe we'll be the one applying these patients and saving more lives. Coming to the present, we have talked past, future, now coming to the present. So this is as per the current clinical practice guideline, which was published just last year, January. They have pulled all the randomized control trials and identified how the patients of ARDS can be managed in accordingly against or with a strong recommendation in favor, or maybe 50-50 in conditional recommendation. So if you see here, the y-axis defines the severity of the ARDS, mild, moderate, severe, okay? And the y-axis based on the recommendation, green goes go, red says don't do it, conditional recommendation, maybe do consider about it. So what is highly strongly recommended is lung protective ventilation. What are these? That's like you have to maintain the goal with a tidal volume at least 6 mils per kilo or ideal body weight. Okay, you can even till reach to 8, but at least manage to between 6. And a safest plateau pressure maintaining less than 30 centimeter of water. Apart from that, it has been more proposed that the patient routinely be done prone positioning, and these are the patients from moderate to severe, and at least 12 hours. We'll talk about other things, and lastly, on the red part, recommendation to be against, not to be applied in your practice, recruitment, prolonged recruitment maneuver. And I haven't been using this, maybe more pediatric and neonatal experts have been using. So high frequency oscillation ventilation. So that been not to be used in adult ARDS. So just to give a summary, treatment goal so far, treat the underlying problem, okay, lung protective strategy to maintain the PA2 between 55, 88, or SpO2 at least less than 95, and between 88 to 95, just not to complicate and avoid oxygen toxicity, and avoid further complication to mechanical ventilation in respect to volutrauma, barotrauma, or atelectotrauma. So these are the things that you can just Google up. And what I do, I just keep in every bedside. Not only the doctors, even the nurses can see what are the levels that I can patch up on the ventilator for the best for the patients. So this can be found ARDS date. There's a 4-page paper. So I'll not go in details. Please look into that. So what's so much important about proning? And it's supposed to be at least done more than 12 hours, and more recommended in patients for moderate to severe as per the new clinical practice guidelines. So what proning helps in patients? If you see the one of the cross-sectional infographic picture, the patient is supine, okay? That's the heart, that's the lungs. And this is a normal patient. This is an ARDS patient. You see all the fluid getting accumulated here. So the patient's, the anterior portion of the alveolar gets aerated. The posterior does not. And when the patient gets proned, your gravity is your ally. If you see here, all the fluid which was at the posterior aspect comes to the anterior, and that anterior portion gets a rest, and then the anterior gets a rest, posterior gets well oxygenated, okay, where ventilation can happen. Apart from that, the heart also gets into suspension coming forward, so there's no weight on the left lung. This was evident with a CT done on a supine patient and on a prone patient, which found out the 28-day mortality in prone patients was lesser compared to a patient who continued on supine. So this is a patient that on the right side we did during the COVID time. So yeah, I know it's requires so much of human resources to turn them supine and prone. I know our third case was a child that was very easy, but if it was 80 kilos, it takes at least 5 people to turn them.
We had recently we had a 150 kg lady. I'm just wondering, like the way we had to gather the whole hospital just to turn her prone. It's quite difficult, but yes, it does help as well.
Right, thank you. At least that was one pointer that really prone really helps us by even the evidence by the practice. Okay, so other thing is like it's on the conditional recommendation, which as per the clinical practice guideline, it's in putting in corticosteroid into the patients of ARDS. Of course, many of the papers evidence say that it reduces the mortality and reduce the patient's length of stay in the hospital. But them pulling all the trials, they found that from 17 was promising, 8 not so much promising because of risk benefit, because the risk of hyperglycemia was high, GI bleed, and even myopathy, neuromuscular weaknesses, because patients ended up staying more in the ICU. The reason being because of all the papers published or the randomized, there was no appropriate formulation or dose or how long the patient needed to be on the corticosteroids. One paper would say 6 milligram of dexamethasone, one would say 20 milligram, and you start tapering. So there is no one consensus what is the dose, what formulation, and for how long the patient should continue.
So, do they say anything about like steroids in diabetic patients who are in ARDS?
So in this paper, they have not anything mentioned about steroids, specifically in diabetic. But yes, in most of the randomized control trials, they did not exclude them. They have included them. So that is the thing that the patients ended up getting into more side effects to the corticosteroids, and the stay in the hospitals was more.
I remember during residency when we were at Loganzilla,
Yeah.
every other patient who was diabetic came in like a DKA patient, and we had to treat we couldn't just say that okay, this is not DKA, because they had acidosis, they had the difficulty in breathing. Yes, it was not like Kussmaul, but still the RVG was super high.
Yeah.
Then we realized that people were giving a lot of steroids based on the different trials that were coming out in COVID-19.
So, um, apart from that, on the conditional recommendation, you can consider neuromuscular blockade. I know it's not a sedation. Why it's given? It's given just to decrease ventilation patient asynchrony. If you are not well synchronized with the ventilator, the patient is not well synchronized, the patient will end up further injure the lung. So basically, it reduces the ventilator-induced lung injury, inflammation, and of course, oxygen consumption and of mortality too. Now, when they pulled all the analysis, there were no really promising results based on all the 8 randomized controlled trials. So some were moderate certainty, other were like low because of increased rate of ICU acquired weaknesses. What we saw even in steroids, it caused myopathy, but even in this. So what were their recommendation was it should be reserved to only patients and should be given to patients maximum 48 hours, okay, less than 48 hours. And should be reserved for patients whose FiO2 is on less than 100, which are in the early severe ARDS. And keeping in mind the patient have to be deeply sedated, and to start an MDA, there have to be an evidence of ventilatory asynchrony. What about high PEEP? High PEEP, but I know in ARDS, as per after the Berlin, they were using high PEEP with low FiO2, or you can use low PEEP with high FiO2. As per this practice guideline, they recommend high PEEP without prolonged lung recruitment maneuver. What means by lung recruitment maneuver? It means that intermittently, okay, the patient is on whatever the PEEP, okay, intermittently you go to the vent and dial up a highest PEEP on whatever you have on the vent for at least 60 seconds. So that had been a practice in the past, but as per the practice guideline, which has been published last year, they go against that. Rather, not to continue with prolonged recruitment maneuver, but stick to high PEEP. Okay, that you maintain high PEEP to a maximal 2 pressure and maintaining the good compliance, of course, with a strict monitoring of respiratory mechanics and hemodynamics. So what about some patients who are extremely severe ARDS? As you can see this chest, you don't see any lung here. It's all totally white out. Totally white out. Very poor compliant. I don't know what vent you can vent this patient. So apart from ventilator, there's an exhalation therapy, ECMO. I know we don't have in Tanzania, but at least we should think of it. And in ARDS, we should think of venous to venous extracorporeal membrane oxygenation.
I was just thinking about the price here, because that's what management thinks about most of the time.
Okay, I will just keep the price part, but since it's a teaching session, I know it's a very expensive therapy, but at least probably in the coming future, we might have this modality and we could help our patients. So just to summarize what it does, there are two big catheters are placed. One is placed in the femoral, one is placed in the internal jugular. In other terms, it's like a lung dialysis. Deoxygenated blood is removed from the patient, gets oxygenated in the oxygenator. You see that machine, and the oxygenated blood comes back to the patient, giving the lungs its good rest. So it's one of the only life-sustaining treatment. So what does the Society of Clinical Practice Guideline recommends? So it's still on the conditional recommendation, but in here it is low certainty. Of course, as per many of the studies, they recommend because it facilitates oxygenation, carbon dioxide removal, and reduces, but it increases the vasopressors use, okay, ICU stay, bleeding, because remember, this the patient comes out, like the blood comes out from the patient, and the patient becomes hemodynamically unstable. So you definitely require vasopressors to maintain the hemodynamic stability. The patients end up also getting into dialysis, so they were on the low certainty. So that, as per their recommendation, they would recommend to choose your patients carefully. Not all patients should be subjected to ECMO. And the criteria are, as long as the patient have an early ARDS course that is less than 7 days, and it's known the patient has less etiologies led to respiratory failure, which are reversible, few risk factors, and is chose patients with level of hypoxemia of PaFiO2 ratio less than 80 or hypercapnic more than CO2 60. Apart from that, we should not forget supportive care. We have talked so much big things. Fluid therapy, the fast hug of all the ICU, avoid boluses, because as it leads to capillary leakage and further interstitial accumulation of fluids. So try to go conservative fluid management. And we always forget about the nutritional support. Our nurses are best, and even our nutritionists are the best. As per the many of the Aspen nutritional guidelines, they've been recommending, though it's not really into practice, high lipid nutrition, high protein diet, and less carbs, which reduces further inflammation and improves patients' outcome. Not forgetting blood glucose, prophylaxis of DVT, and GI stress. So, just to summarize, what we knew about the past, okay? We know about the disease. We troubleshoot our way through from the past. Got the definition right, okay? Did our treatment well by lung protective strategy using NMB, prone position. What is the future? We are looking forward to stem cells. Probably in the coming 20 years, we are looking towards that, at how we can not only manage but cure ARDS. Thank you.
So let's see now. We've been offered. All right, so it's time for some discussion, and let's see if there are any questions here. I don't really see any questions. Guys, do you guys have any questions? I'm allowing you to be unmute. And then we can take some questions, and then both of them have come from work, and I would like to let them go early. So let's I think I would like to talk to Dr. Nikhil first, because he has some experience in COVID-19, and while everyone was intubating, we had successfully, I remember there was a case whereby we had successfully kept that patient on CPAP only, and he came out. But you know how God works. Unfortunately, he passed away on a car accident. So maybe Dr. Nikhil can talk about that case. Why did he choose not to intubate in that part?
Hi, good evening, everyone. See, uh, now let's, as Dr. Ismail already said, that ARDS over the period of past, say, I'll say from 1994, it has evolved. The definition has evolved. The treatment has evolved. Everything has evolved, right? So, what is happening if we see from majorly see from 1994 till the latest of guidelines of 2023, which was published in 2024. Okay, the world one, the latest one, guideline 2024. It it see first, the major thing was how to define ARDS, which we all know by that time it is not a disease itself. It's a sequela of some other thing, either a direct injury to the lung or the indirect injury. Now, till when Berlin definition came and everyone was, I'm not against any definition, I'm not against any guidelines. I'm just trying to figure out what happened over the period of time. And over the period of time, was said like 2012 Berlin lines. It's a landmark, big two. Yes, it is, no doubt to it. And then we started, we really started ventilating our patients as per ARDS.net guidelines, and it was again told that it's a landmark guideline for the for the ventilation, and still, it is, yeah, this was something which really protected the lungs of many individual in many part of the world. But here we have to understand one more thing, one small little thing. These guidelines, or this was made in an way to understand, like, if the patient is ventilated in a country which is a bit resource less country, or where there is not much understanding of the ventilator, or there is one ventilator running around in the whole hospital. So, how to keep the patient safe, or we are short of specialists, right? How to keep the patient safe? That's why these guidelines came in. But so, and we followed it. Good thing to follow that. But in an institutions, like when we come up across an institution, we also have to understand, when we treat ARDS, if this guideline was given, if this ARDS guideline, first we had to ask, as a specialist, as an intensivist, as a critical care physicians, as physicians, where did this guideline come from? As an AHA, when they put up a guidelines, the good thing about AHA is that they also put their proofs why we did it, the good physiological explanation. And similarly, we as physicians have to understand why they said low tidal volume, high PEEP, or low FiO2, high PEEP. Now there can be so many things. I can ask a simple question: what do you mean by high PEEP? And another question I can ask, like, for a patient who is cacaxic or 40 kg, lean, thin, but a good height, will you ventilate him in the same manner with a low tidal volume, high PEEP, against a patient who is fat but short, but the weight is the same? Can we ventilate them on the same manner? I don't think that things will work, because high PEEP might induce a barotrauma in that. So we have to understand why it happened, why we used why was it given. That was understand. So if we understand the pathophysiology to it, what was happening in COVID. So if we said, as Dr. Ismail said, it was in three phases, like proliferative and this phase and the third phase. Now, as soon as, because, you know, as soon as these patients in our part of the world, they used to come usually a bit at a later stage, when we are already out of the proliferative state, or the patient was already in fiber. Now, you tube that patient of the fiber. What I saw in there, initially, we used to tube, the patients never used to come out. So you tube those kind of a patient, it's like a cement lung. What are you going to achieve out of it? So the main sympathetic drive of the patient, or the respiratory capacity of the patient, we also used to hamper it by using this neuromuscular blocking agents of the sedation. And they were also on steroids. Maybe somehow the lung is poor, you are tubing the patient, you are putting them on steroids, on top of it, maybe a sedative or a neuromuscular. How do we expect that patient to come out of all that stuff, even if the lung parenchyma somehow into was the that? So in that's why I usually never used to intubate the patient unless and until it was not very badly required, unless and it was not something of life and death. I used, otherwise in intensive care it is said that use a low threshold for intubation. In other ARDS, use a low threshold of intubation. But that's why I usually, and Dr. Moise knows that we did pretty well. Our mortality was really low. I'm not saying it was zero, it cannot be zero. But I still have the statistics or something. And we did well. People did come out. People did come out of being on NIV after being on at least 30 days. Patient he was talking about is he was the guy was on NIV for around 30 days and applied to the same stuff. I also even had some patients with malaria who went into the bad ARDS. Now we have to understand we live in a country where resources are the problem. So some relative told, no matter what, don't intubate the patient. Then what? We pull them through NIV. Sometimes we even broke the nose of the patients. But yes, they pulled it out through. So again, it's in the hand of the God, as Dr. Moise told. That patient unfortunately died later in a car accident while driving to some other. So my point out here, guidelines are good. They have to be followed. But as an institution, as a physicians, it is our role, duty to also understand why it was written, to understand the pathophysiology of a process. And then you yourself can go to the ventilator and see whether this, for example, ARDS now tells me this thing, and we don't have ECMO. We placed on the maximum setting. Now it is not working. Now what do? We call up the ARDS type guidelines. Can't do that, right? Yeah, we have to have a good understanding of the ventilator, and that knowledge has to be passed. We need to have a good understanding of the pathophysiological stuff. That has to be passed. And then that's how we work. And that's why that's the logic I use in the COVID patients.
Just, uh, just to add on that, what Dr. Nikhil, I know every hospital had gone through various experience during the COVID time. Of course, we also had it. It's even my hospitals, we had to choose our patients who really required to be on the ventilator because of the resources we had. We would not intubate each and every patient because of the low resources, and then uh, we one thing what we had noticed during the COVID time, it's not the ventilator was causing the problem, it was the oxygen itself was a problem. And gladly we managed the patients without even giving them oxygen. And and we managed to publish one of the case report. It was supposed to be a case series, but we managed a patient with a moderate ARDS category. Okay, uh, in that patient without even giving oxygen, as Dr. Nikhil said, we tried to uh, break the bond of the guidelines. Okay, and maybe that bond breaking, maybe a new guideline might come up. Okay, so I'm glad that that publication got so much citation to some researches, observational researches. That's why some researches are going on right now in in a conservative and liberal giving of amount of oxygen. So what we learned during the COVID time, like especially for this patient, when patient had no any respiratory distress, and when we never look at someone's SpO2, we just switch off the SpO2. We treat the patient clinically rather than the numbers, and the patient apparently come out very well. If you put them on oxygen and they are very much hypoxemic, you are giving them trouble. Okay. And adding extra ventilator, because ventilator does not go on its own, it goes along with an oxygen. Eh? There is already a fire. You're going to put a kerosene on top of it, and from the fire, it will become a havoc.
I think that those are good experiences that we have learned so far. There is a question from the forum here, and I think as experts, you guys can answer. But before we answer this question, I would like Dr. Adnan to give his inputs on pediatric population and how would he, like in a summary, what is the key difference? Because as we know, pediatrics are not small adults. So, Dr. Adnan, what will you think about ARDS in pediatric population?
Thank you, Dr. Moise, and thank you
for the nice presentation and explanation and experiences on COVID in terms of your experiences in COVID. Okay, so in pediatrics, I would say that the major difference there's one in definition. The way, apart from the pulmonary edema being a non-cardiogenic source, the other difference is those with the neonates with prematurity or complications arising from prematurity are excluded. The other exclusion is a neonate with meconium aspiration syndrome or non-congenital heart disease. So these are exclusions in the pediatric population. Again, I want to emphasize on what Dr. Ismail said regarding the PEEP, positive end expiratory pressure. My experience is that giving a PEEP of, say, 9, nurses and medical officers in ICU would really be afraid, like, Doctor, this is a very high PEEP. Are you sure you want to do that? But remember, you want to use high PEEP versus low FiO2. So, I mean, if there's one thing, if we have medical practitioners working in ICU, if there's one thing you want to carry home, don't be afraid. Use that 9, use that 10. If you're using 9 and 10, but giving an FiO2 of 60 or 50, that is better than rather than giving 100 versus maybe 7. So yeah, that is one experience I had during my fellowship that we really achieved, and I'm impressed that adults get out of ICU within 3 or 7 days. Our pediatric patients stay in ICU for almost up to 2 weeks. Oh, probably they are more sick.
I would even go high PEEP till 25. Of course, not 25 continuous, like 25. Of course, monitoring its best plateau pressures to let at least 30, even it can just pull to even 32. That's from perfect. And high PEEP and minimize the FiO2. I can even go FiO2 to 25%. That's the current I am practicing.
Thank you. So yeah,
In pediatric patients, in the neonates, do you still use HFOV or not? High frequency oscillatory ventilations in patients like who are premature or is it still used or how is it?
okay. My practice in the neonates is not I'm not more into 2 months plus, but use it in infants. Though the only one machine in Kenya, yes, but we use it.
So it is used. HFOV is used in infants and all, right?
Thanks.
All right. Let's move on to the question. This is a favorite drug for people working in Muimbili for some reason. My brother Harry here is asking, can we use ulinastatin in reducing the inflammatory reaction? Over to you guys.
Well, I'll use guidelines. Guidelines guide us. Okay. Um, I and just a guideline was just published just last year. I was also surprised they never even mentioned anything about any immunomodulators. Okay. I think the favorite drug which was roaming around during the COVID time was tofacitinib. Is it? Yeah. So, sorry. No, tole, yeah, yeah. I've even forgot the name. Yeah. So, yeah. So they, yeah. So immunomodulator. So, the whole thing was to modulate the cytokine. It's not like to switch off the cytokine, but to modulate them. And on the other hand, ulinastatin, it's an interleukin-1 or interleukin-6 inhibitor. So it kind of modulates, but it has not brought anyone's attention in respects to guidelines in worldwide, but more locally. Maybe I have like a lesser experience on ulinastatin. Maybe the usage of mine were like very few. So maybe I can't really so much comment on ulinastatin. But I would say that if you have to understand ulinastatin, where it directly works. So ulinastatin was manufactured or discovered in Japan, if I'm not mistaken, and that was ideally used in patients with pancreatitis. Uh, and it inhibits one of the proteolytic enzymes in the pancreas, which releases the cytokine interleukin 1 and 6. So it's a very good drug for that pancreatitis patient, but uh, many of the authors, clinicians thought like, let's use ulinastatin outside the pancreas. Yes, maybe it can be used in the ARDS situation, but coming to the bottom line, coming to the guidelines, no any recommendation to any immunomodulators, including ulinastatin.
Okay. So, uh, Dr. Ali, I think you know.
Earlier.
Yes. We cannot say ulinostatin may help with inflammation. Is there no credible comparative study to suggest so? In addition, ulinostatin is more expensive than other anti-inflammatory. I think you have already mentioned that ulinostatin does not have enough data
Yes.
to support its evidence in other than pancreatic ARDS.
Yes.
So we should follow guidelines, but is it harm to try?
Yeah, it's maybe Dr. Nikhil can help me out.
Yeah.
On this.
See, the question is there harm to try? Again, don't take me wrong, I'm not against guidelines. But the thing is, yes, guidelines have to be followed. It should be followed. We are living in the 21st century. We can't say my professor used to do this, so I'll also do this. That doesn't work in today's world, right? So there has to be internet. There needs to be evidence-based guidelines which have to be following. Having said that, before that, anything, for example, tomorrow ARDS comes with a guidelines. For example, then tomorrow ARDS comes with the guidelines. Okay, use ulinastatin or use some magic drug. Okay, we as physicians, without thinking, if we start using it, what then? As happened in with ARDS or ARDS.net guidelines or the others, as soon as the COVID came in, everyone sat after that. Dude, let's rethink. Things are not working. So similarly with ulinastatin or any other drug, you have, as a physicians, you have to use the pharmacokinetics of that drug. How does it, as Dr. Ismail said, how does it help? Then the pathophysiology of your disease where you are trying to apply it. Okay, if it is an inflammatory, for example, I'm just giving if ulinastatin works on the proliferative phase and the patient is already out of that, what is the point of giving then? So you have to correlate. That's why in reports or correlate clinically. You have to understand the pathophysiology of that disease. You have to understand the pharmacokinetics of drug and where I am using in which condition. Is it even correlate? Then you go to the guidelines, what evidence says, what data says, and what not says. But you should not be harming the patient. That's also very important. But if it is not harming the patient, it doesn't mean you'll start using in each and everything. Okay, there is sepsis. Let's use ulnastatin. There is ARDS. Let's use ARDS. That means if it is already features of ARDS and the lung X-ray is bad, that means we are already out of 7 to 10 days. We're out of that proliferative phase. Is it really gonna help? We could not come up with a solution of corticosteroids till now. Do you really think in this we can come up with a solution for that? Again, clinical correlation is very important in each and everything.
Let's take a last question and then we can call it a day. So, do we have a new mode of ventilation better in ventilating ARDS patients with good outcome? Do you favor a mode once? And do you favor a mode? That's the question.
It is more individualized. Okay, there's nothing favorite. Everyone's favorite is different depending on what ventilators you use. See, ventilators are like cars. Okay, one cars have all the specification. The other car will not have that. Okay, so it's same as like one ventilator will have that mode, the other one will not have. So based on what resources you have, it's not like you have to favor that ventilatory mode, because that's the resource that you have. So in my terms, because I don't have like very high-end ventilators, okay, I don't have high-end ventilators. Of course, these really work, and in correlating with the researches and the level of the evidence, yet they have not identified which is more superior or one is inferior. So I had been using the same primitive ventilatory modes. Pressure, if in the pressure mode, pressure control ventilation, in the volume assist control, and SIMV pressure support. I know there had been other modes of APRV, and there had been like more intelligent modes like adaptive uh, adaptive ASV modes. I can't remember the whole abbreviations. And then there are other modes as per different ventilators you have. So I don't know what Nickel has to say on the modes, or maybe what's his favorite mode that he uses.
See, again, I'm not against guidelines, but you have to again understand when you first question to ask why I am intubating a patient and why I'm ventilating it. Is it a therapeutic measure or is it a supportive measure? Supportive measure, use anything. Therapeutic measure, again, you again have to understand what are my goals out of it. So I cannot tell you use a PAC mode or a VAC mode. No, I'm no one to tell that. You have to sit with the patient, sit with the ventilator, and work on that. It's like driving a car, as Dr. Ismail said. Some cars are small. Have you gone into the hilly areas and driven a car? If there is a small car, it's better there. You take a Land Cruiser or a big car, you'll get stuck in the traffic jam. So it depends. What do you want to achieve? There are no, as in Chang, there's a book on ventilator, Chang. It's clearly written out there, right? Use the mode which you are comfortable with. Even if it is a fancy ventilator, even if it is not a fancy ventilator, you have to first understand the pathophysiology, why I am tubing the patient, what are my goals, and what do I want to achieve out of it. Then you achieve it in a PRVC mode, APRV mode, VAC mode, or PAC mode. The thing is, end goal has to be achieved. So, one line answer, there are no specific modes in my clinical practice which I tell my subordinates or colleagues that this should be used. And I don't think, to the best of my knowledge, there is any kind of recommendation on any specific mode on which patient has to be ventilated. I think so. That's my answer.
Okay, so that's it for us. I think thank you to Dr. Ismail for presenting. Thank you to Dr. Nikhil for being the panelist. Dr. Adnan from all the way from Kenya for being a panelist. And yeah, after a month, we are going to have another of these talks. It's called EM Cross Talks. So the whole point is you might have seen the difference between these kind of talks versus the other ones. That we want to make it more interactive, like a school like a discussion like, because as per research, it shows that 50% of retention that you get is after discussion. So whatever we discuss with Dr. Ismail, it will be remembered more compared to him just lecturing. And that's the whole point of such talks. So we are going to have these talks every month, and I'm going to try and bring new speakers. As you can see, this I've become an RG right now with all these gears and all that. And yeah, I'm trying my level best, and I thank you for your support. I hope that everyone has registered through the Zoom link. I'm not going to be biased for this case. If you have registered, I'm going to give you a certificate. And majority of my certificates have been uploaded in MCT, and MCT has provided CPD points according to my friends. So if you are a doctor and you're looking for MCT points, I'll give you a certificate, and that certificate can be used to claim. For now, we are still working on the CPD organization rights. Once we get that, then I guess even we can provide those kind of points to all of you. So thank you very much and have a good night.
Follow-up to 10 years. Salaam, nafurahi kupata elimu toka kwenu. Thank you, Nikhil, for your advice.
All right, they're thanking you.
All right. Thank you. Thank you so
Thank
much.
so much.
Yeah. Thank you for your inputs too.
We will share the recording on YouTube channel. Don't worry, I'm going to send everything on email. You have registered, so that means you have registered with your email. All right, good night, guys. Bye-bye.
Bye.